Hi, I'm Jeff Klein, editor of RadioGraphics, and today I am pleased to have with us Dr. Khaled Elsayes from the University of Texas MD Anderson Cancer Center, Dr. Ania Kielar from the University of Ottawa in Ottawa, Ontario, Canada, and Dr. Claude Sirlin from the University of California, San Diego, who are the authors of our featured paper in this month's November 2017 issue of RadioGraphics. The paper is entitled Liver Imaging Reporting and Data System, or LI-RADS version 2017, an update. Drs. Elsayes, Kielar, and Sirlin, welcome to the podcast.
Thank you.
Thank you.
Khaled, we're going to begin with you. Your paper in the current issue is an important one, and it provides our readers with an updated pictorial on the revised LI-RADS, which was released this year in 2017. Can you please describe how LI-RADS began and how it's evolved over the years?
So good morning first, Jeff, and thank you very much for inviting us for this podcast. It's our pleasure to be here, and it's my pleasure also to be with Dr. Sirlin and Dr. Kielar, great colleagues, and who have contributed significantly to this. And Claude is chair of the steering committee for LI-RADS, and myself and Ania Kielar are co-chairs of the Education and Outreach Committee of LI-RADS in the American College of Radiology. So as we all know, hepatocellular carcinoma is the most common primary malignancy of the liver, and it's the second leading cause of cancer-related deaths in the world. That's why HCC is very important, and HCC that develops in symptomatic patients is associated with 5-year survival of less than 10%. However, if it can be treated early with transplantation or resection, the 5-year survival rate greatly improves, and that's why it's very important to detect hepatocellular carcinoma at an early stage by means of screening, which is very important for an optimal outcome. After screening and detection of the lesion, then comes the role of contrast-enhanced CT and MRI, and potentially now contrast-enhanced ultrasound after the FDA approval. In most current clinical practice guidelines, CT and MR have replaced biopsy. So if you have a lesion with imaging features that are characteristic for hepatocellular carcinoma, then it's imaging diagnosis. We make diagnosis. We don't need biopsy. In North America, the American Association of for the Study of Liver Disease and United Network for Organ Sharing and Organ Recruitment, the Transplantation Network, like UNOS and OPTONN, have provided diagnostic guidelines for patients at a high risk for hepatocellular carcinoma and liver transplantation candidates. These organizations provided criteria for diagnosis of hepatocellular carcinoma that are based on imaging features such as arterial phase hyperenhancement, washout, capsule appearance, lesion size, and tumor growth. So it's our proposal, our LI-RADS is contemporary to UNOS OPTN, and it's building on AASLD, American Association for the Study of Liver Disease. The LI-RADS was developed by diagnostic radiologists with the support of the American College of Radiology by providing definitions to these features, and it also has created lexicons, algorithms, schematic, and addressing gaps in these systems. So LI-RADS is intended. What's the aim of LI-RADS? It's intended to reduce variability in the interpretation of imaging findings. It also intended to improve communication through standardized reporting and facilitate therapeutic decision-making and outcome monitoring. It was designed for use by community and academic practice radiologists, as well as radiologists in training, researchers, and any healthcare professional involved in providing care to patients at a high risk of HCC. We're dealing now, Jeff, with the third update of LI-RADS. So LI-RADS was initially released on 2011, and there were 2 updates in 2013 and 2014, and now we're releasing the third update of LI-RADS. This is version 2017.
Terrific. Thank you very much for that. Khaled, following the introduction in your paper, you begin with an overview of the new LI-RADS version 2017, which focuses obviously on the use of CT and MR in the new LI-RADS version. Can we look at Figure 1 and discuss the new additions and clarifications that appear in the new LI-RADS version 2017?
Absolutely. Let me pull up Figure 1. So in version 2017, there were brand new categories that were created and others that were expanded, all using evidence-based data and expert consensus. This included a new algorithm for LI-RADS characterization in the context for ultrasound surveillance and screening for patients at a high-risk HCC. There was also a separate algorithm was developed for liver lesions being evaluated using contrast-enhanced ultrasound, given its increased use throughout North America after the recent FDA approval of microbubble contrast agents. Also, in the area of treatment response, there was significant work done to expand this area and to include the standardized terms, such as non-viable, equivocal, viable, or even non-evaluable based on the treated observations imaging. So number one here, we have some new algorithms, okay? And we have also some new and modified categories, such as LI-RADS M. So LI-RADS M is malignancy. So I think LI-RADS NC, which is non-categorizable, and LI-RADS tumor in vein. This was a category that was modified in LI-RADS version 2017. Also, for LI-RADS M, I was going to say that there was explicit new criteria for LI-RADS M, which is malignancy specific for definite features or probable features of a malignancy other than hepatocellular carcinoma. In addition to that, ancillary features have been also expanded and built upon. So, but at the same time, it's very important to note that we changed this in LI-RADS 2017. This is no longer mandatory for the version of 2017. It's optional due to lack of sufficient evidence in the literature to support mandatory incorporation of these features. There was also modified definition for tumor growth. So that's mainly the new additions in LI-RADS version 2017.
Terrific. Khaled, thank you for that. Claude, we're going to turn to you. The paper in this issue is obviously a very important one, and it really provides our readers with an updated pictorial on this revised LI-RADS, which was just released. What motivated the updates, and why should radiologists and the allied specialists who are caring for patients with known or suspected hepatocellular carcinoma use LI-RADS?
Thanks for that question. So Khaled also already outlined some of the updates, but very briefly, what motivated the various updates were to address gaps in the previous versions, as well as continuously attempting to further simplify the algorithm. So, for example, in version 2013, we added the category LI-RADS M to recognize the fact that not all cancers in the cirrhotic liver are HCC. So this was an important category to alert the referrer and the patient that there may be a cancer other than HCC in the liver. We also created an algorithmic display to facilitate the interpretation and use of LI-RADS, and we added an atlas of controlled terminology, schematic drawings, and illustrative examples. That was 2013. 2014, we added hepatobiliary agents such as gadosetate disodium, and we simplified the algorithm. In 2017, we added ultrasound, we added contrast-enhanced ultrasound, we added treatment response, and we further simplified the algorithm. So in summary, the updates are intended to address gaps and to further simplify. Now, why should radiologists and allied specialists use LI-RADS? We believe that LI-RADS is currently the leading and most comprehensive system for imaging liver cancer in patients with cirrhosis. It provides rigorous standardization of imaging, not only for clinical care, but also, we believe, equally importantly, for research and for education. LI-RADS is a dynamic document, so unlike other guidelines, which can be updated only every 5 to 10 years, LI-RADS can be updated as evidence accrues, as new knowledge is formed, and very importantly, in response to user feedback. LI-RADS also has an international perspective. We now have over 250 contributors to LI-RADS from every continent except for Antarctica. So there's a broad international perspective that is helping to make sure that LI-RADS is relevant, not just the United States, but ideally to the whole world.
Terrific, thanks. Claude, let's look specifically at one new diagnostic category. This is the LR-NC, which was added to LI-RADS in the most recent version. Can you detail this category, when it's to be used by radiologists, and what the recommended follow-up would be for these patients with this particular designation?
Now, that's a great question. So LI-RADS non-categorizable, or LI-RADS NC, is to be used rarely and only in the situation where the radiologist cannot decide whether an observation is more likely benign or more likely malignant due to image degradation or image omission. So, for example, if a lesion is challenging because it has unusual imaging features, but the actual imaging is fine, all the phases were obtained and were good quality, do not apply LI-RADS non-categorizable. Do your very best to apply the best category you can. Also, even if images are omitted or degraded, but you can narrow the list of categories to being more likely benign or more likely malignant, then don't apply this category. So, for example, if I know something is a LI-RADS 4, 5, or M, but I'm not sure exactly which one of those it is, I would not use LI-RADS non-categorizable. I would say the imaging is limited. I believe this is a malignant mass somewhere in the LR4, 5, or M category, and I would recommend further follow-up, which then leads me to your next question. What is the follow-up? And I would say that depends on several factors, and so the radiologist will need to use his or her judgment. It depends mainly on what the cause of the non-categorizability was, as well as the size of the observation and the urgency to figure it out based on clinical factors. So, for example, if the reason that something was non-categorizable was because someone was breathing during the arterial phase, then it may be as simple as bringing the patient back with better breathing instructions if the radiologist thinks it might work. Similarly, if the arterial phase images were just not acquired, it would be as simple as bringing the patient back and acquiring the missing images. Now, sometimes it might require more judgment. So sometimes it might require a different contrast agent or a different modality. We don't have rules that can outline every possible scenario, so we leave it to the radiologist's judgment. The last thing I'd like to emphasize, though, is that if in the radiologist's judgment no imaging alternative is likely to be helpful, then at that point we would recommend multidisciplinary discussion between the radiologist, the hepatologist, and possibly other healthcare providers with consideration of biopsy or other diagnostic workup.
Great. Thanks very much for that. Ania, we're going to turn to you. So LI-RADS TIV, or tumor in vein, is a new descriptor that replaces the LI-RADS 5V designation that was used previously. Can we put up figure 3, which illustrates a patient with this particular finding?
Absolutely. So the term LR5 was changed specifically to tumor in vein for the version 2017 to address cases where tumor, not just Len thrombus, is identified at cross-sectional imaging. And this term is supposed to indicate unequivocally enhancing soft tissue in a vein, regardless if you visualize an associated parenchymal mass. And as a tip, during your radiologist's interpretation of contrast-enhanced MRI, use of subtraction images may be helpful for this evaluation of presence of tumor in vein. Previously published studies have shown that presence of tumor in vein is associated with worse patient prognosis, which is why this term was specifically included in and separated from the LR5 designation. In addition, Tumor in vein is a term that is important to the American Association for Study of Liver Disease, and it affects decisions regarding further treatment, management, as well as liver transplantation. So, based on these, when somebody identifies tumor in vein, the next step is multidisciplinary discussion, and this is key because based on these discussions, biopsy may be considered for definitive diagnosis as well as individualized management as informed by the final pathology. It's also important to note that most observations categorized as LI-RADS tumor in vein are in fact HCCs, but it is important to remember that there are some differential diagnoses to consider, which are rare but worth giving a thought. One of them is the possibility of tumor in vein due to cholangiocarcinoma, or in rare instances, a hepatocellular carcinoma and cholangiocarcinoma together. So therefore, not all malignancies with tumor in vein can actually be categorized as LR tumor in vein. In those very rare instances where a radiologist thinks that this may not be HCC, it should be indicated specifically in their report that there may be another primary malignancy involved. On the other hand, if there has been a previously pathologically proven HCC with tumor in vein, then you can say path proven. And if it was pathologically proven not to be an HCC, then you would simply say this is a cholangiocarcinoma with tumor in vein.
Right. Thank you for that. Ania, let's discuss the concept of threshold growth, which is in the new LI-RADS. Can we review this concept? And we'll also show figures 5 and 6 to illustrate this concept.
Absolutely. So in order to determine growth, it's first imperative that we all measure in a meticulous manner and adhere to standards. These standards are provided and emphasized in version 2017 of LI-RADS. So if we look at figure 5, this is where we talk about the definition of how to measure size. So the key first point is to include outer edge or edge of an observation. In the case where an observation has a capsule in it, we want to the outer edge to the outer edge. If an observation is not round but is oval, then we would look at the major axis or the longest length. In the case of heterogeneous observations or nodules in nodule, then we would like to include the entire observation, including the areas that are more enhancing and enhancing. Now, it is important to remember that if an observation has an area of perfusion abnormality, then we do not want to include the perfusion abnormality. And that's why currently in LI-RADS, we do not recommend measuring the arterial phase unless that is the only phase which is where the observation can be well seen. Now, once the size of an observation has been accurately determined, we can talk about growth. And in that case, we have to compare to previous cross-sectional imaging. So threshold growth is one of the major features in version 2017 of LI-RADS, and it is now defined as a minimal 5 millimeter increase in lesion size and either a 50% or greater increase in size before or at 6 months, or a 100% increase in size after 6 months. This is a little bit different than OPTN because OPTN only has one definition, and that is greater than or equal to 50% increase in size in 6 months or less. So these slight differences need to be kept in mind. And the implication is that some LR5 observations may not count as OPTN5. So in particular, this would affect observations that do growth for LR5 categorization. And for OPTN, it's only those that have more than 50% increase in size in 6 months or less. So the other difference between OPTN and LI-RADS is that OPTN applies to all transplant candidates, whereas LI-RADS only applies to eligibility criteria. And specifically, in LI-RADS, we do not currently include pediatric patients, and we do not include vascular causes of cirrhosis. Now, if we look at figure 6, we've been given 4 images. One is in the early arterial phase, then we have a mid-arterial phase, a late arterial phase, and a hepatobiliary phase in this particular case. And we can see that the measurements, if you took the long axis, outer margin to outer margin, would in fact vary quite significantly. As we try not to any of the arterial. So in this case, we would use the hepatobiliary phase, which is image D, and this would be what we would use. The key feature at this point is that radiologists should use the same plane between studies, and whether it's axial or coronal, and the same phase. That will maintain the most accuracy of intra-movement between the two studies. And hopefully in the future, with improvements in deep computer learning, segmentation of observations may be easily created and accessible to radiologists for more accurate evaluation of these observations.
Great. Thank you so much, Ania. Khaled, let's turn back to you and let's discuss the approach to assigning a LI-RADS diagnostic category 4, in 4 steps rather, that you detail in the paper. We'll review figures 12 through 14 as we discuss the 4 steps in assigning a LI-RADS category.
Okay, thanks for this question again, Jeff. So there are, looking at the table or figure number 12, so there are 3 main steps. First, we evaluate the observation using the imaging provided and ensure the quality of imaging is sufficient for characterization. Then we look at the major imaging features, which includes presence or absence of arterial phase hyperenhancement, washout, presence of a capsule, and threshold growth. Once this is done, as well as, of course, measuring the size, once this is done, a preliminary category is assigned. Then it comes table number 3. We look at number 3, because after this step, we look at the ancillary features, evaluate them, though these are not currently considered mandatory using LI-RADS version 2017. So if we look at, now we're looking at table 13, which describes the various ancillary features. Some will upgrade an initial LI-RADS category up by 1, while others may downgrade the category down by also 1. Okay, so you may upgrade it by 1 and downgrade it by 1. You can't upgrade it or downgrade it by more than 1. But it's also important to know that, no ancillary features can lead to increase in the LI-RADS category beyond LI-RADS 4. So you cannot assign LI-RADS 5 based on the upgrades by ancillary features. If there are more than one ancillary feature, they can cancel each other, one another. So you have one that upgrade, one that downgrade, they can cancel one another. And if one favors a benign entity and one favors a malignant features, then they can cancel each other. However, this cancellation cannot change the original categorization of an observation by more than one category. Again, reminding with the value of ancillary features, it won't go beyond LI-RADS 4. So you cannot go to LI-RADS 5 based on upgrade by ancillary features. And then the third step is apply tiebreaker rules if needed. So if we are unsure between 2 categories, we should choose the one reflecting lower certainty. If we are unsure about tumor in a vein, then we don't categorize it as tumor in a vein. This is the third step. And the last step, if we look at it, is a final check. And this is it's meant to be really confirming what we are looking at. The final check is after steps 1 and 2 and 3. What we do is we ask ourselves if the assigned category makes sense, seems reasonable and appropriate. So if yes, if it's really reasonable, then we're done and we're moving to the next observation. If there is any next observation in the image, But if it doesn't make sense, it's not reasonable, it's not appropriate, then a signed LI-RADS category should be inappropriate, and we should actually reevaluate. So those are the 4 steps for the diagnosis for applying the our algorithm in CT and MRI diagnostic algorithm.
Great, thanks so much. Claude, let's just turn back to you. Next in the paper, you detail the technical recommendations of performing CT and MR exams in patients who are at risk for hepatocellular carcinoma who are being evaluated by cross-sectional imaging. And Figure 18 reviews these recommendations specifically. Are there any points that you'd like to make on these recommendations?
The most important point I'd like to make is that LI-RADS currently applies to multi-phase CT, multi-phase MRI with extracellular agents, or multi-phase MRI with hepatobiliary agents such as gadoxetate disodium. I'm frequently asked whether LI-RADS applies to MRIs performed with gadoxetate, and the answer is unequivocally yes. So that's the single most important thing I'd like to emphasize. I'd also like to emphasize that the technical recommendations on this table and in LI-RADS are minimum technical recommendations. They reflect what we believe is the minimum required for appropriate imaging of liver cancer in the setting of cirrhosis. It's based in part on evidence, in part on expert opinion, in part on a desire to minimize radiation, and in part on practical considerations. So, for example, to minimize radiation, we currently say that pre-contrast CT is optional in those patients who have had no prior treatment. We also say that diffusion-weighted imaging is optional, and the reason for that is that not all scanners in the United States currently can do high-quality diffusion-weighted imaging. So as a practical consideration, we make DWI optional, not mandatory. Now, we allow users, of course, to add if they would like. So, for example, those users that have the capability of doing multi-arterial phase imaging may choose to acquire multiple arterial phases. We don't require it. We don't recommend it, but that's an option. Now, as I mentioned, a lot of this is based on expert opinion and practical considerations. Not all of it is based on evidence. And so we're hoping that with research, we might be able to figure out what phases and what imaging sequences are truly incrementally valuable and which ones are redundant. So maybe with time we can reduce some of the requirements, but we need research to do that. And the last thing I'd say is that one controversial issue that I would love to see some research on is whether, in fact, pre-contrast, unenhanced CT should be acquired before giving contrast. There are reasons to do it. There are reasons not to do it. I would say this is a controversial issue. In 2017, LI-RADS make this optional, but I would love to see some research to determine whether or not the incremental value of pre-contrast CT may actually outweigh the small risk of additional radiation exposure.
Terrific. Thanks, Claude. Ania, finally, let's touch on treatment response categories and the criteria for assessing residual or recurrent disease, which is new for LI-RADS version 2017. We'll show Figure 24 that details the process of making this assessment. Ania, would you like to review this for us?
Absolutely. So before I go into the actual figure, I just wanted to say that LI-RADS treatment response assessment was advanced for this version of 2017. It was developed by an international group of multidisciplinary LI-RADS treatment response working group, which includes radiologists, hepatologists, and radiation oncologists, as well as interventional radiology. And it is important because there are many different local types of therapies which can occur, and we need, as radiologists, to be familiar with the enhancement patterns of these treated tumors. So that's the first thing to remember. If we actually go through the way that this is built, by using the LI-RADS treatment response, it allows radiologists to have clear communication between radiologists and specialists caring for patients who have undergone local regional therapy. It also provides standardized terminology with the terms of viable, equivocal, and non-viable to facilitate data collection. And as Claude mentioned in his responses, research is still an area of need in this particular region, and it is something that's increasing in the literature right now. When we look at this particular treatment response algorithm, the first thing to look at is whether or not we can evaluate this. So the term non-evaluable is used for treatment response, as Dr. Elsayes explained earlier. It is actually important to differentiate non-categorizable from non-evaluable. Non-evaluable is used exclusively when evaluating an observation that has undergone local regional therapy, such as radiofrequency ablation, stereotactic body radiation therapy, or various catheter therapies. The term non-evaluable should be used when a treatment response cannot be evaluated due to image degradation or omission of various sequences. So that's the first part. Once you've looked and determined that the imaging quality is acceptable, then we have three options. One is non-viable, and those are instances where the interpreting radiologist feels that there's no tumor left. Generally speaking, those are areas of non-enhancement. Term tumor viable, LI-RADS TR, indicates that there is something left over after the treatment. And the one in between is equivocal, that we use that term. So in equivocal, the enhancement pattern may either be atypical for a treatment-specific expected enhancement pattern or definitely viable.
Terrific. Well, I'd like to thank Dr. Elsayes, Kielar, and Sirlin for joining us today to discuss their featured paper in the current November 2017 issue of Radiographics on LI-RADS version 2017 and update. Doctors, thank you very much for taking your time today.
Thank you very much, Dr. Klein.
Thank you.